Top-Bed Talk.
Hi, my name's Gerard Danjoux and I'm a consultant anaesthetist at South Tees Hospitals in the north of England. I'm going to talk to you today about the Prepwell Project, which is a community-based prehabilitation programme which we run in Middlesbrough in South Tees and was initially set up in January 2018. Just to show you members of our team, we have a range of people from anaesthetic registrars to physiotherapists and also health trainers from our public health facility, the Livewell Centre in Middlesbrough. On this slide, I just want to make some brief declarations around the Prepwell Project, which I'll give you a few seconds just to look at. Broadly, there are three categories which might influence perioperative outcome of patients, which relate to patient-related factors, healthcare professional-related factors, and also system-related factors. The Prepwell Project was set up to try and incorporate mainly patient and system-related factors. So, for example, when we look at patient-related factors, we are aware that a number of patients approach surgery with undiagnosed or poorly optimized comorbid disease and also with suboptimal lifestyle behaviours such as excess drinking or inactivity, which are known to adversely influence outcome. From the point of view of system-related factors, this broadly revolves around inefficient pathways of care, our general target-driven mentality, but also fragmented provision of services available, particularly in the public health domain. So, for example, patients wanting to access exercise on referral schemes or smoking cessation programs often have to do so in different settings at different times in the lead up to surgery, and subsequently engagement, as you might imagine, is not fantastic. So in setting up the Prepwell Project, we established the following guiding principles. We wanted to provide patient-centred care under one roof with facilitated self-management. We wanted to work as a cross-sector collaborative. So by that I mean primary care, secondary care and public health all working together to try and improve on the fragmented service provision, silo work that we often see in our healthcare services. We wanted to provide a community-based facility for patients, and I'll come to the reasons for this. The pilot itself ran between January 2018 and January 2019. So this slide just shows an advertising flyer for the Prepwell Project or programme, which we posted up in various areas of the South Tees hospitals. And this was really just to get a kind of visual of what we were doing, and a number of patients responded to this by asking their surgeons and pre-assessment staff what it was about and about participation. This slide provides an overview of the aims and objectives of the Prepwell programme. So at the top of the pyramid you can see our primary aim was basically to develop and implement a pre-operative community-based health and wellbeing programme for a range of patients before surgery. Our secondary aim was to demonstrate improvements in patient health status and quality of life following programme participation, and the terms entry and exit will become apparent in subsequent slides. Our objectives ranged from an ability to demonstrate effective cross-sector working through to providing pilot data for service sustainability. So why did we choose a community-based venue? Well, leading up to implementation of Prepwell, we've done a lot of research and workshop patient-facing work. And the simple answer is that patient choice mandated that they really didn't want to come and do their prehabilitation in hospital. Ease of access was better in the community. They could park easily, and the cost of parking was often much less. And for those who couldn't drive, we chose a facility with good transport routes. We used an existing public health community facility in Middlesbrough called the Livewell Centre. This was a facility which had recently undergone a near £1 million refurbishment and really is a nice venue. For patients who didn't want to attend face-to-face services, we provided home-based self-supported options, although it's important to say this was our preferred option. How was support provided? It was provided in a directly supervised manner for patients attending the Livewell Centre, and patients attended from a range of different specialties in groups of 6 to 8 twice a week. For those who chose home-based prehabilitation, this was done in a facilitated way with regular contact from our project manager. Patients were also supported by receiving a pedometer and some basic exercise equipment such as stretchy therabands for muscle training. This is just a photo of one of the main gym in the Livewell Centre, showing you the range of equipment available for patients to use. We also had direct access to a smaller room at the back of the facility where we housed a range of equipment enabling patients to undertake exercise in a kind of circuit-type class. Other key components included a multimodal nature, so we weren't really just focusing on exercise, for example. We were focusing on identifying and treating the full range of unhealthy behaviours, including smoking, alcohol excess, and providing nutritional support and psychological support. We also used short validated screening assessments for undiagnosed comorbidities such as frailty and cognitive impairment. The programme was delivered by health trainers who were employed by Public Health South Tees, with direct oversight from our physiotherapy team. The programme was aligned to cardiac rehabilitation, which we used as our model of care. We use this because this has been a very successful model of treatment for patients over the years, both in the UK and internationally. This slide provides an overview of our patient pathway, which, as I've said, is a model based around cardiac rehabilitation. So once patients had been seen by a surgeon or in a pre-assessment clinic, they had the opportunity to be referred for entry into the Prepwell programme. We kept the referral criteria very loose, and clinical champions were able to refer in if they felt a particular patient would benefit from prehab before surgery. A referral was sent to the Prepwell Project Manager. The Prepwell Project Manager then contacted the patient and arranged an entry assessment, which took approximately 60 minutes and was done face-to-face in the Livewell Centre. This was a one-stop evaluation using questionnaires and short validation tools for risk behaviours, health status and quality of life. On completion of the entry assessment, a multimodal prehabilitation package was agreed with the patient, which was then signed off by the clinical staff. And that might, for example, include an exercise programme, referral to smoking cessation, and nutritional support. The prehabilitation phase of the programme itself was ideally designed to last between 4 and 8 weeks, depending on type of surgery and requirements before surgery. Patients were primarily asked to attend supervised face-to-face classes at the Livewell Centre on 2 occasions per week, lasting approximately 60 to 75 minutes. At these sessions, we also provide information on surgery school, and also patients had the opportunity to directly ask the project manager about any concerns or queries they had in relation to their management. The Livewell Centre, importantly, provides all lifestyle services under one roof, providing a one-stop facility and getting rid of the problem of fragmentation in service provision. On completion of the prehabilitation phase, patients were asked to re-attend for a 30-minute exit assessment, which was to evaluate changes in risk behaviours, health status, and quality of life. On completion of surgery and hospital discharge, patients were again contacted 12 weeks later by telephone. This was to evaluate for sustained behaviour change and quality of life, and also gave us an opportunity to capture any post-op data, such as visits to general practitioners or physiotherapists. This slide briefly overviews the target risk factors of interest, which include lifestyle behaviours, cognitive impairment, anemia, obstructive sleep apnea, and anxiety and depression. All of these are known to adversely influence perioperative outcomes, if not optimally managed. This slide overviews the entry assessment on the left, as I previously described. On the right-hand side of the screen, we have the target risk factors and the screening tools which were used to assess and diagnose. Just some guidance for activity and exercise, for example, we use World Health Organization compliance with international guidance. So, for example, to see whether patients complied with 150 minutes a week of moderate intensity exercise and 2 sessions a week of strength training. We also used the 6-minute walk test. Anxiety and depression was assessed using the validated hospital anxiety and depression score. Nutrition with the BMI and MUST tool. Obstructive sleep apnea using the stop-bang short screening tool. Frailty was assessed using the clinical frailty score and Edmonton frailty score if required. Anemia and diabetes, looking at recent blood profiles, although it's important to say that we didn't undertake bloods for the purposes of Prepwell. And the risk of post-operative pulmonary complications was assessed using the ARISCAT score. This provided us with an opportunity to provide inspiratory muscle training for patients at high risk. Available interventions are covered on this slide. So, for example, for activity and exercise, we were offered a structured, supervised, graduated exercise program or a home-based facilitated alternative. For smoking and alcohol, patients could either receive brief advice from the project manager, who is trained in delivery, or could access direct delivery to the services either through the LiveWell Centre or their GP. When patients had evidence of anemia, they were referred rapidly into our hospital's anemia investigation and management pathway. Nutritional support was provided where required through industry products from Nutricia. From the point of obstructive sleep apnea, we were able to perform expedited sleep diagnostics supported by our hospital sleep unit and establish patients on CPAP as required in a very short space of time compared to routine care. The results I'm going to present are purely from the pilot phase of the programme between January 2018 and January 2019. Overall, during the pilot phase, we had 159 patients referred to the programme, with 75 patients accepting participation and 84 patients declining. So just over half the patients declined. I'll go into that in more detail in due course. Of the patients accepting participation, the majority, 2/3, were male, and the mean age of the cohort was 69 years, probably consistent with the general surgical population. As you can see, the majority of referrals were made encouragingly by surgeons, and also the majority of referrals were from vascular and orthopedic surgery, which probably reflects the buy-in of our clinical champions in those specialties. Next, looking at patients who decline Prepwell. Obviously, this is very important because in future, if we want to increase upon this, we need to look at these reasons in more detail. The majority of patients, 30 out of 84 in fact, simply weren't interested in participation. The next most common reason for non-participation was logistic travel and transport arrangements, which probably reflects our population, which has a number of deprived areas, and also it's a large tertiary geographical area, with patients often being required to travel more than 25 miles from some of the tertiary referral areas. a number of patients simply were having surgery in too short a time frame for participation. Of those accepting participation, the majority, 54 out of 75, participated in the face-to-face programme, and 21 out of 75 opted for a home-based alternative. The remainder of the results will focus on those who chose the face-to-face programme. This slide shows the large geographic area which South Tees Hospital serves, and to give you an idea, to travel from North Durham at the top of the screen down to Northallerton at the bottom is about a 50-mile drive. The majority of patients were referred from the immediate catchment area of South Tees. However, a number of patients were referred and were in the supervised service from as far away as 30 miles from the Livewell Centre. This table covers or summarises the outcomes from the pilot. At the top of the table, you can see enters the assessment undertaken prior to participation. Exit represents the assessment taken on completion of the programme, and 3 MPS is 3 months post follow-up or post-surgery. The first thing I'd like to draw your attention to is the number of patients complying with World Health Organization aerobic exercise guidance. So what you can see on entry to the programme, only 17% were complying with this. However, on programme completion, this had increased dramatically to 75%. Encouragingly, 63% of patients reported that they were maintaining this activity level at 3 months post-surgery. Next, if we look at patients who complied with both aerobic and strength training guidance, we can see that nobody complied at entry. However, this had increased to 73% at exit from the programme. There's a drop-off down to 29% 3 months post-surgery, which is likely to reflect the fact that people were continuing with the aerobic exercise guidance, as you can see above, in the column above, in the row above. However, the numbers seem to have dropped off doing the best strength training. When we look at objective fitness assessments, the mean 6-minute walk distance had increased by 35 metres from 444 metres on entry to 479 metres on exit. This would represent a clinically meaningful improvement. In fact, 56% of patients achieved 25 metres or more improvement, which in cardiac rehabilitation is a clinically meaningful improvement. When we look at other lifestyle behaviours, including alcohol and smoking, we can see that the number of people drinking above recommended guidance levels reduced from 17% on entry to 4% at 3 months post follow-up. We found that very encouraging. Unfortunately, however, there was very little difference in smoking levels between entry and 3 months post follow-up. Finally, we can see that anxiety and depression levels gradually reduced from entry to 3 months post follow-up, which is encouraging. But the main thing I'd like to draw your attention to is the changes in health-related quality of life, which were measured using the EQ5D. The score is between 0 and 1, with 0 representing a perceived state of health equivalent to being dead, and 1 representing a perceived state of health as being perfect. So you can see relative improvements of 20% between entry and exit, and 45% between entry and 3 months post follow-up. We were very encouraged by this improvement. Next, just to cover the money part of delivery, what we performed was a cost-consequence analysis, and overall, the mean cost of the supervised programme per patient was approximately £400. This varied by specialty, but was mainly determined by duration of the programme, as you might expect. So leading on from that, we worked out a mean cost per patient per week, which came out at £50, approximately £50. This incorporated staff, equipment and facility costs, and I think would represent a highly competitive figure when you look at the cost of perioperative care in its whole. There were also unanticipated benefits. So, for example, we started receiving referrals from initially unexpected sources, such as the abdominal aortic aneurysm screening programme in the north of England. The project received endorsement by what you might call initially sceptical surgeons. There was a kind of overspill effect through the clinical champions who over time achieved referral from their colleagues, and we saw quite a beneficial effect in that respect. The programme was also an enabler for patients who had initially been too high risk to have surgery. So, for example, within it we have a fairly well-established abdominal aortic aneurysm pathway and multidisciplinary team assessment performed. And 3 to 4 patients were initially deemed too high risk following objective assessment, physiological assessment, and surgical and radiological evaluation. These patients subsequently were provided with the opportunity to go through Prepwell, were reassessed subsequently, found to have significantly improved fitness levels, and subsequently underwent uneventful surgery. That opportunity would not have been available 3 years ago. Importantly, we need to look at patient-reported outcomes. There were 2 ways that we did this, using semi-thematic interviews recorded over the telephone with consent on a one-to-one basis, and also audiovisual recordings, again, performed with patient consent. The first question we asked from semi-thematic interviews was framed around, why did you choose to take part in the programme? So you can see the majority of patients were focused on getting through the operation. However, we saw other themes around people just wanting to get out and socialise. It was a stressful time before surgery. The second question was framed around, what changes have you noticed as a result of participation? So again, you can see a range of representative answers, from people just feeling better and having more confidence, to people admitting that they'd lost what they considered to be a significant amount of weight, and breathing better, and just generally having improved attitudes towards life. And that would be consistent with the results I presented around health-related quality of life. The final question was framed around how would you approach life going forwards, and you can see a range of answers again from people wanting to go to a local gym or just get back to activities that they enjoyed in a prior period of their life. When we look at audiovisual recordings, I think the best way to provide feedback on this is to provide you with a short video of some of our patients who participated in the programme, and this is now shown in the next 90-second clip.
And I loved it. You met new people, you did the exercises, you felt well in yourself when you came out, because it helps your mind as well.
With the incentive I've got now, I've got into cooking, like healthier foods, stir fries and things like that, rice and noodles and things like that. Just and it's I enjoy it, yeah. So it's been good. I lost 1.5 stone in 6 weeks, 4 weeks. I mean, I really pushed myself, but I did it because I knew if I didn't, I probably wouldn't survive. I wouldn't be sat in this chair today.
It's going well, I think. It's going okay. I'm enjoying it. I feel better when I've done it. So yeah, it's going good. Once the sessions are over, it makes you feel as if it makes you feel you've achieved something, and you also feel better in yourself because you've done some exercise, definitely worth your while, because it does make you feel better. Even if it's not just for the exercise, if it's for the socialisation, if it's for talking to other people who haven't done what you haven't done, even if it's talking to your physio, and they can help you out with things that you didn't think they probably could help you out with, and it can just make you feel better if you are having a bad time.
Leading on from that, we now are in the next stages of the Prepwell programme. So we've now taken the learning from our pilot, worked together as a team, and we're moving forward with our developmental aims. So these include meeting different needs of patients, going down different surgical pathways, widening access of prehabilitation to a wider group of people, making optimal use of more regional facilities, so basically trying to spread the programme beyond the Livewell Centre, and importantly, using a digital patient database, which I'll come to in a minute. From the point of view of widening access, we have developed a specific high-risk pathway, which will be focused around the delivery of the pilot that I've just talked about. We'll have a 2-year focus on developing pathways around vascular surgery and requiring intervention for cancer. We are also in the process of setting up an orthopaedic pathway, which will be higher volume and lighter touch or demedicalised. And thirdly, we are working with Macmillan Cancer Support to develop an evidence-based digital home-based programme. This is different to the digital patient database that I mentioned a few seconds ago, which is basically a live dashboard tracking system whereby patients are able to answer many of the questions for entry and exit in the home setting without the need to come to face-to-face evaluations for such a long period. This will also help with service monitoring, audit and research, as well as providing a live dashboard as to where people are within the Prepwell programme. This slide again overviews our current pathway. However, in red, you can see the areas that we feel will be significantly enhanced by the digital patient database. So as I've said, that the entry and exit assessments will be primarily done at home, dramatically cutting the requirement for face-to-face work. And also, rather than telephone assessment and follow-up, we will be able to send patients relevant questionnaires through the online platform. We see this as a major component of our programme moving forwards to improve utilisation of our staff and also provide a more focused patient service so people don't have to make repeated unnecessary visits to the hospital or to the health centre. Importantly, our entry assessment is modelled around being merged with pre-assessment. So what that means is that we'll be asking questions in detail, a reasonable level of detail, and we'll then be moving towards using the same platform for pre-assessment so that patients will only have to answer the questions once, and when they attend for their pre-assessment appointment, or whether that's done online, the answers will already have been provided during their prehabilitation assessment for those who have been through the programme. So the team are quite excited about that development. Well, we can't finish really without discussing the impact of the last 12 to 14 weeks and the effect that COVID-19 has had on our services. Consistent with the majority of services internationally, we have had to move all of our patients to a home-based setting due to the potential increased risk of infection in gyms. Our home-based resource has been developed with a lot of hard work from our project managers, Esther and Sam, supported by some of the health trainers and other members of hospital staff, and is set up around a welcome or introduction, an exercise resource, and a nutrition resource. The welcome is Well, I've flippantly called it Hello from Barney, who was one of our vascular surgeons, shown in the video screenshot at the bottom right of the screen. The welcome pack is framed around 3 short videos, which provide an overview of the programme and an introduction to prehabilitation. Stage 2 is our exercise resource, and again I flippantly called Exercise with Esther, who you can see at the top right of the screen. Esther is one of our 2 project managers. So the exercise resource is structured in 2 ways. Firstly, you have an exercise video library, which you can see on the left of the screen. It's a series of short videos showing patients how to perform exercises safely. This is essentially a reference instruction manual for patients. Then we have a 30-minute class, which is regularly updated, usually on a 2-weekly basis, for patients to do with Esther in their home setting. Importantly, the exercises are framed and for patients to be able to conduct them safely within their home environment. For patients not wishing to do the Exercise with Esther video, we have a PDF which they're able to view online or download of a circuit comprising aerobic and strength training exercises. Finally, we presently have a nutrition resource available, kindly provided by Lucy Winter, one of our specialist dietitians, and this is called Healthy Eating with Lucy. Again, this is a 3-minute video describing how to optimise your eating prior to surgery. We are presently working on a mindfulness support resource. For anybody wanting to have any further information about the outcomes of our pilot, I would refer you to our recent BMJ Open Quality publication. So in summary, we have found that implementation of the Prepwell Project was feasible with effective cross-sector working. So we feel that we met our primary aim. There was very good patient feedback and engagement with the project, although there was the concern of approximately 50% of patients not wishing to take part, and that's something we have to be mindful of when providing services moving forwards. We saw improvements in health status indicators and quality of life, which was sustained up to 3 months post-surgery, so that enabled us to meet our second aim set out in the original pyramid. We have a series of ambitious future plans, which we're working on as part of a Sport England funded local delivery pilot in South Tees called You've Got This, and this involves working very closely with our public health colleagues over the next 3 years. We've had to do rapid resource changes secondary to COVID-19 over the last 12 to 14 weeks, which have had several beneficial effects, including forcing us to improve the quality of the Homebased programme which we're delivering. And finally, we're delighted to have been shortlisted for BMJ Team of the Year 2020. Unfortunately, I'm unable to share the outcome of that with you because, like everything else over the last few weeks, the meeting has been deferred. Hopefully, will be undertaken later in the year. So please watch this space for that. Please cross your fingers that we'll be awarded it. Finally, just a few acknowledgements to share with you, particularly around our core team members. Our project managers, Esther and Sam, have worked diligently over the last few weeks, particularly in supporting patients and creating resources. They've both become experts in videoing with iPhones and video editing. Thanks to our fellows, health trainers, and also our academic evaluation team from Northumbria University. I'd like to say thank you for collaborating partners in the project listed below, and of course to the funders, the Health Foundation and latterly Sport England, who have enabled the project to become a reality. Thank you for listening.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.